Well, hello again. It's Jason Renault with the Alternative Mobile Services Association, and today AMSA Talks is speaking to Jacob Rosen from Eureka Care. Hello, Jacob. How are you doing?
Doing well. Thank you for having me, Jason.
Thanks for being here. Thanks for doing the work that you're doing. Let's start by your telling us a little bit about you and how you got into this line of work.
Yeah, so my name is Jacob Rosen. I'm the managing mental health clinician for Crisis Alternative Response of Eureka. I've been in this position since August of 2022. So I came over and we developed the program from scratch in collaboration with the Eureka Police Department. My counterpart over there, Commander LaFrance, has been instrumental in developing this from the ground up. They did a lot of the groundwork to create such a program and getting city council approval and all that. And so I started there 3 years ago, or 3.5 years ago now. Before that, I worked with the county and their behavioral health system, working pretty much
Hmm.
any like crisis-related behavioral health department that I could get my way into. Started with the crisis stabilization unit, and that was kind of my home unit for the 6 years that I was there. But also worked inpatient on separate virons, which is an inpatient psychiatric unit. And then also did mobile response, where I would go and do 50-on-50 evaluations in the ERs, moonlit in the jail, doing safety cell assessments, and even managed to land myself a spot on the crisis negotiations team with the Humboldt County Sheriff's Office.
Oh,
Uh,
okay.
and
Huh.
so I've been doing that for, gosh, 4 years now. Um, Graduated in 2020, or sorry, 2016, with my master's degree in counseling psychology. Technically, I'm a licensed marriage and family therapist, though it's ironic because I don't really see couples or families. I mean, I guess we do in crisis, right? But that's not the unit of care. But kind of got sent this direction by a professor in that program, and they thought that I would do well in crisis work. And at first, I thought they wished harm upon me, and learned that they didn't, and fell in love with it. So here I am.
Very interesting. There are a lot of LMFTs in crisis work. It does seem to, it's not intuitive, but it does seem to work.
It does, and it's not something that, although my experience has been, it's not something that's really heavily trained in any of the master's
No.
level clinician programs. That this is an option, but I'm happy that I found my way into it.
Now you mentioned this was birthed in part through the Eureka Police Department. This is a non-police team, right? This is not a
It is.
co-response team.
Yes, so we do both co-response. We do a blended model, just
Mm,
because of the size of our town, and we can talk more about that.
yeah.
But the size of our town, really, there isn't the demand for a dedicated co-response or a dedicated alternative response
Mm.
model. But we definitely have a high demand for crisis services. And so developing a team that's able to kind of blend and do both co-response and alternative response was really critical. And we are technically separate from the police department. We do work within a police annex with the police department's in-house mental health team, the community safety engagement team. And so they are just down the hall, actually, from our offices. But we are technically separate.
Well, that's very, I mean, I think geography really shapes a team. One of the key forces that causes a team to be one. Tell me a little bit about the community that you live in.
Yeah. So Eureka is a coastal city. We're the county seat for Humboldt. And so, the bulk of services are down here. We have the corrections facility. We have Semper Virens, the inpatient hospital. We have Providence St. Joe's hospital, which is the, biggest hospital in the county, and our only trauma center. We have a population of about 27,000 people, but during the daytime, our population goes up to about 55,000 people. And so we have a huge influx of people coming into Eureka to work.
Hmm.
Um, and so we have a unique situation where we kind of have a very small town, but because of being the biggest city in the area, we get a lot of folks coming in, and so we kind of expand. So even though the residential population is not that large, the daytime population is pretty significant.
But this is a
Uh,
city-funded program, not a county-funded program.
Correct, correct. So in 2018, the city developed its own mental health team within the police department, the Community Safety Engagement Team. And that's a dedicated team comprised of officers that are specialized in mental health, having extra training, going through the crisis intervention team training, as well as basic negotiations and often advanced negotiations. And then also in 2018, the city developed its own social services team,
Mm.
Eureka. And Uplift Eureka really specializes in doing a lot of housing work. So connecting folks with rapid rehousing or getting them on the coordinated entry list, connecting them with HUD, doing a lot of street outreach and that sort of thing. When the pandemic happened in 2020, the city really became aware that it needed its own crisis team. There was a lot of frustration in how the collaboration with county services was occurring at that time. At that point, that kind of birthed the initiative to work toward that independent team under the city banner. And so in 2022, they were able to get the council approval and kind of make everything happen and fall into place. And I was very fortunate to be able to kind of jump over to the city from the county at that point. And Commander LaFrance and I have been working together for quite a while in the beforehand, so it was kind of a natural shift.
You've worn both hats, both county and city, and seen both sides of this problem. What was this conflict about?
So I think the issue has largely been related to agility. The city is a very nimble, our city especially, I mean, with 27,000 people, employees under the city, 300 to 350 roughly at any given time. It's a much more nimble ship to steer. It's much more agile in being able to pivot to, hey, we identified this problem. Let's identify a solution to this problem and let's just get staff dedicated to go and do it. And there just isn't as much red tape in terms of, that problem identification and then going and creating a solution to manage it. Whereas the county level system has so much more burden in terms of, especially in the behavioral health realm, in terms of state requirements and federal requirements and where that funding comes from and what services they're mandated to provide, what services they're not mandated to provide. And then they also tend to be larger organizations. And so it's a much bigger ship to steer, and it's a lot more difficult to pivot and make changes to a program on a level that the city of Eureka was looking for. And so that kind of discrepancy is what really drove the desire to have, the city's own in-house team.
And you couldn't get the county to be nimble, so you had to create it your own.
Yeah.
I think this
Yep.
is playing out all over the country, to be honest with you.
I've seen similar when I go to CIT conferences and
Mhm.
when am at League of Cities. There definitely is a theme of cities having some frustration at solutions not being fast enough or targeted for their city's needs. And I mean, I understand the organizational challenge, right? I mean, you're already breaking things into counties, and if you're going to be distributing federal or state funding, distributing it down to individual cities makes a huge system to track, and each city having its own mental health department is going to be inconsistent because you have some cities that may say, well, that's not in our charter, so we're not going to deal with it. It's not our responsibility. You have other cities saying, well, our responsibility of our charter is to take care of our citizens. And if this is what our citizens need, we're going to do it. Um, it could be difficult to figure out the funding allocation for individual mental health departments within counties that are already getting that. So I understand why it's the way it is. And at the same time, we still have an issue, and that issue is not going to go away. And so if we're not going to, kind of solve that problem at a grander scale, then we need to move forward with it. And the city wanted to do that. So
Well, it sounds like, you're on top of it. It is a complicated problem, and you're in the perfect size community as a petri dish to work this out and really make it one for one. So, really can make a difference. Let me ask you a little bit about, you've had some big advances in the care program in the past year, some big some very interesting data. And I don't know that we can extrapolate and say that you've had the impact that was recently in the news article of reducing 15% of the calls to 911. But tell me about the data that you're collecting and what you're seeing in it.
So I think there was some clarification needed just around that statistic. The 15% reduction in 911 calls wasn't solely related to CARE's efforts. What they found is there's a 15% reduction in 911 calls just due to the city's a real push for proactive policing in collaboration with CARE. And so the Eureka Police Department's really had some amazing efforts in having more proactive traffic work, proactive engagement with those in the community who are experiencing issues, trying to engage them and find solutions and support before it gets to a crisis. And that combined with CARE, which is also meant to be a proactive program, right? I mean, we want to be able to intervene before it gets to a 911 call and arrest or a 911 call and a 5150. We've been able to see that reduction, even though we've also seen about a 19 or 20% spike in mental health calls for service overall
Hmm.
across the last year. And so we do a lot of data collection. I'm very fortunate. My partner over in the police department, Commando France, does a ton of data collection, both with their computer dispatch system. There's been a lot of work put into tracking mental health calls for service, so we know how many calls for service are coming in every year. We also track how many calls of those are being sent to CARE, and what is co-response, what is alternative response, and that sort of thing. And then on our end, we also do a lot of data collection as well. So we look at what types of calls we're getting. We also track whether we're doing co-response or alternative response. The diversion rate is probably the biggest or maybe the sexiest number that folks look at. How many folks are we diverting away from the hospital? Especially because that's the big topic, right? How do we help psychiatric patients not end up in the ER?
Right.
And so that diversion rate is often something that, whether it's grantors for funding or whether it's, a city council or other entities, that's one that most folks like to hear. And so we do our best to do all that data collection because we know that it drives, the outcomes. We know that the data that we collect now is going to drive the outcomes a year from now. And that's because we're going to use it to pivot our program if needed. We're going to use it to apply for more grant funding. We're going to use it to apply for different types of services so that we implement different types of services so that we can maybe meet a need that we've identified as there that was not previously being addressed. And so we do quite a bit of that.
So, can you give us any specifics about, say, programmatic changes you've made based on data you've collected?
Yeah, I mean, our expansions have largely been data driven. We started very small in 2022. It
Okay.
was just me, and I kind of built the framework for the program.
Yeah.
We launched formally with staff in January of 2023. To start, we had two case managers. We had two case managers and myself, and we started seeing clients and going out on calls. At that point, we were co-response only,
Hmm.
uh, and we're kind of we read up and done our homework on what other programs look like, but hadn't really solidified a specific model for what care was going to look like. And as we started to ramp up with the two case managers and myself, we were able to look at call volume and we're able to look at what our diversion rates were and recognize that we're not meeting demand. There are more crises that law enforcement is being dispatched to than what the three of us are going to be able to
Yeah.
accommodate. So, we sought solutions and funding, and then we were able to expand. We were able to by the end of 2024, we were up to four staff and myself, one clinician, three case managers, and myself. And so 2024 through 2025, we were able to, kind of continue that work and continue to again to identify that we weren't meeting demand, particularly in that we were operating Monday through Friday with that crew.
Hmm.
And so we're happy to announce that by February 22nd of 2026, we will be expanding to 7 days a week. And so we've brought on another case manager, and we also brought on an admin technician for some back-end support. Because as we continue to see more clients, we have more demands than I can field in program management. And so, that's kind of a prime example. I mean, as we continue to see the numbers grow, and still not meet that demand, that's really driving kind of where we put the energy and how far we're going to expand.
Oh, congratulations. That's just in a week or so to
Yeah.
be doing that expansion. That'll be very exciting. Now, you're making these decisions based on data, but you also have to use the data to sell this idea to fund this new position. How's that
Yep.
work?
Taking the data that we're looking at and then also looking at some of the outcomes, right? So care sits at 75 to 80% diversion rate.
Mm,
So a 75 to 80%, depending on the quarter, of calls that we go on, we are able to divert that person away from going on to a 5150. And so we know that we're able to divert folks to lower levels of care, and that helps relieve burden on the hospital. We also know it helps relieve burden on law enforcement. And so, we track that. Another thing that we started in 2025, in March of 25, was a true form of alternative response. We up to that point we had been doing a co-response model, but a co-response model where once the scene was safe, we were dismissing law enforcement back into the community to go attend other calls, while we continued to handle the call that we've been brought out to for a mental health crisis. In March of 2025, especially just seeing the numbers of law enforcement contacts for mental health crises, we were able to launch alternative response where now dispatch will send a two-person team to a call independently, if there's no violence, no weapons, and no history of violence. So when that person's on the phone with 911, so long as they are not describing any violence, or the reporting party is not describing any violence toward other people, and there's no weapon, and there's no like officer safety warning flag in their
mhm,
system, they'll dispatch us independently. And so, looking at the demand, making the adjustments, and then demonstrating the effect by showing how much time we save officers, then we're able to then, bring that data back and present that as, hey, we know this works. We know we're saving officers time and we're getting better outcomes because we have folks who are specialized to do this mental health work, and who have the time to do the case management component and do the crisis prevention component. It's one thing to go out to an individual in crisis and work with them and de-escalate them and then walk away. It's another thing to then, hopefully stop them from re-entering crisis in another 24 hours. And that takes time, and law enforcement often doesn't have that time to spend with folks.
We often think of mobile crisis as two-person teams, but it sounds like you really have a team of dozens. There's lots of people who have touches on every one of these encounters. Tell me about some of the champions you have in your community that are really making this possible.
I think we froze there.
Oh,
Yeah. Uh, you said a team of dozens and then get it cut out.
so it sounds like, mobile crisis, we often think of it as teams of two, but it sounds like you have dozens of people who are touching every encounter here that have a little piece of the action. Can you tell me some about the champions in your community that are making this work?
Yeah. I Commander LaFrance with the Eureka Police Department. I mean, really all of command staff over there, including the dispatch supervisor, have been amazing. I mean, our program would not function as smoothly as it does without their leadership and collaboration. Everything from integrating our policy and procedure with dispatch to even just how safety, works on a call. For example, our team is the one who is allowed to dismiss an officer. An officer is not, barring a severe, a catastrophe, right, or a school shooting or something like that, then obviously officers are leaving to
Mhm.
go attend to that. But for the most part, our team is the one who decides when an officer is leaving, and they've been very supportive of that. And so the idea that mental health staff would have control over whether an officer is on scene or not, and we can dismiss them, is something that requires some trust and really requires some leadership and guidance to make that work. And EPD in general has been a huge partner in that. So yeah, Uplift Eureka is another kind of ingredient to our success. They've been incredible partners in terms of being able to take off some of the weight of getting those social services components put in, whether it's finding clothing for someone who is, out in the rain and all their clothes are wet and they're in crisis, and we're able to de-escalate them, but we don't necessarily have a clothing stock here at our offices, and so then we can go and work with them and the street outreach team to get that remedied. Also just getting folks into coordinated entry. Sometimes folks are in crisis because they don't have housing. That's a huge issue. We know that housing is a determinant of health. And so we know that crisis revolves around that. And so by being able to work with another team to make sure that folks are working on the housing component while we then, can take on any of the mental health concerns or any of the crisis de-escalation, is a huge reason that we're able to be as successful as we are. Um, in terms of support for the program, we've had a bunch of champions in the kind of political realm. Our mayor, in particular, Mayor Kim Burgell, has been a huge champion of mental health over her term, including even having her mayor's initiative revolve around mental health and doing mental health education. But overall, all of City Council has been incredibly supportive. They're very receptive to my reports when I get to go and report to them, and have been very supportive in terms of giving us the positions that we need and something like that with grant funding or some of the county funding that we've been able to secure. The city has been very, very supportive in making sure that our program stays consistent, really recognizing that consistency in crisis services is a key factor in that success.
Mm.
And we couldn't do that without, our political leaders supporting us.
Well, congratulations, Jacob. Thanks for visiting with us.
Yeah, thank you for the opportunity. I appreciate it.
Best of luck.
Thank you. Take care.